FLIP stands for Functional Luminal Imaging Probe, a novel technique that uses impedance planimetry to assess EGJ distensibility, volume and pressure changes in the esophagus, and esophageal motility. The method is done during an OGD, and therefore you give the same sedation as an OGD. Put a balloon catheter with 16 sensors inside, and you get a 3D image of the esophageal lumen. So it gives you a cross-sectional area, intraballoon pressure, and the luminal diameter. It assesses EGJ-DI, distensibility index, which is calculated as a cross-sectional area in millimeter square divided by the pressure in mm mercury. Normal EGJ-DI is more than 2.8. The lower values indicate impaired GEJ opening. This is the picture of the EndoFLIP, which is used to assess esophageal distensibility and diameter. So the left panel is the diameter or the CSA topography plot over time, where the x-axis is the time and the y-axis gives the position along the balloon from the esophagus to the EGJ. The colors: blue represents narrow or collapsed segment, green-yellow shows moderate opening, and red is the widest and the most distended part. Here the central red band is the balloon-filled esophageal lumen. The wave-like oscillations suggest contractile activity or secondary peristaltic contractions, which are RACs or RRCs. The right panel is an hourglass image, which is the most important part. The balloon shows an hourglass narrowing at the center, which corresponds to the esophagogastric junction. The upper balloon is the distal esophagus, the narrow waist is the EGJ, and the lower balloon is the stomach. So the EGJ is less distensible, or it's tighter than normal in the waist. And we read it as 6.5 millimeters is the D-min, or the minimum diameter at the narrowest point. And the one on the right, that's 0.6, is mm square per mm mercury, which is the distensibility index. The interpretation of this: normal EGJ distensibility should be more than 2.8 millimeter square per millimeter mercury. But here you have only 0.6, which shows it's not opening. This strongly suggests either EGJ outflow obstruction or achalasia. FLIP panometry is the next thing, which calculates the motility. And there are three types. One is RACs, which are repetitive antegrade contractions. This is normal. Repetitive retrograde contractions, RRCs, which are abnormal, and diminished disordered contractile response. This is also motility disorder, which is abnormal. The uses of FLIP. In achalasia, when the HRM is inconclusive, EGJ-DI is low. RRCs may be present, or there could be absent esophageal motility, or there could be DDRCs. It is used in intra-op assessment during a POEM procedure or Heller surgery. And you can check the adequacy of myotomy, which places it at a huge advantage compared to an HRM. It can predict the response to a pneumatic dilatation as well. So a change of EGJ-DI of more than 1.8 gives a good response. Post-treatment assessment of EGJ opening is also done in achalasia in FLIP. EGJ outflow obstruction. It helps to distinguish a true EGJ outflow obstruction from a false positive with a manometry reading. And it's useful to evaluate non-obstructive dysphagia. In GERD, more distensibility EGJ, more prone to reflux. It's not routinely recommended in GERD management. Eosinophilic esophagitis, it measures esophageal stiffness and it evaluates distensibility plateau and the narrowing. And there's decreased distensibility and correlates with rings, strictures, and a need for dilatation. For upper esophageal sphincter also, a flip can be used, and this is only a research tool right now. The advantages of EndoFLIP are: it can be done during an endoscopy with the same sedation, so it's more comfortable for the patient compared to an HRM. It takes a short time, less than 5 minutes. You get a real-time assessment of anatomy and physiology, and it's useful for diagnosis, especially when a manometry is inconclusive. Distensibility plateau is generated 3 to 10 centimeters above the GE junction, max diameter at each impedance channel during each incremental distension, that you increase the distension from 50 ml to 60 ml to 70 ml. That is plotted down. The narrowest diameter for each volume is plotted by the nadir intra-balloon pressure, and the normal should be more than 18 mm. So the differences between HRM and EndoFLIP: HRM measures esophageal pressures, primary peristalsis, and bolus clearance. EndoFLIP measures luminal distensibility and secondary peristalsis via impedance planimetry. The procedure: HRM is a transnasal catheter, and the duration takes about 20 to 30 minutes. While an EndoFLIP is endoscopic guided, it's real-time 3D imaging, and the duration is 10 minutes, much less. The comfort level in HRM is more uncomfortable because there's no sedation, but in a flip, there is sedation, so more comfortable. The metrics are LES is what is measured, the IRP in the HRM with esophageal pressure topography, but in a flip it's EGJ-DI, the diameter, and the contractile patterns. The role of HRM: this is the gold standard for achalasia, and flip is done only in obscure diagnosis. The advantages are: HRM gives you a comprehensive motility evaluation, and a flip will guide you intra-op and helps you to make decisions while on the table. That's a good advantage. Prior to a flip, you should have a high quality endoscope, use 16 centimeter flip, filter the setting to off mode, and the reference pressure should be set at atmospheric. So this is how it appears. You first give the 50 ml balloon, then you stepwise increase it at 30-second intervals to 60 and then to 70 mm balloon. To read HRM: the baseline features: first, identify the upper esophageal sphincter, the LES, the crural diaphragm, PIP, and the basal EGJ pressure. The types of EGJ morphology: you determine it by type 1, in which the crural diaphragm and the LES overlap each other and the PIP is at the same level. Type 2, there's partial separation of the crural diaphragm and the LES, which is less than 2 centimeters, and the PIP is at the level of the crural diaphragm. Type 3, there's a separation of more than 2 centimeters, and that means there is a large hiatus hernia. This could be a 3A or a 3B. In 3A, the PIP is proximal to the crural diaphragm, while type 3B, it's proximal to the lower esophageal sphincter. Now, what is PIP? PIP is a pressure inversion point. It's a point at which there is a transition from positive deflections in the intra-abdominal cavity to negative deflections in the intrathoracic cavity during inspiration. Normally, it's immediately above the proximal end of the LES. It's important to identify a hiatus hernia. Absent PIP means that the catheter is not placed across the LES, so we have to reposition it. Then we do a swallow assessment, and there are these measures that we take. First is the IRP, which is integrated relaxation pressure. It's the measure of 4 seconds of the lowest mean axial pressure during the first 10 seconds after a swallow. The normal is less than 15 millimeters of mercury. In the setting of achalasia type 1, we have to use 10 millimeters as the cutoff. Otherwise, more than 15 millimeters indicates a EGJ outflow obstruction. Second, the contractile deceleration point, CDP, the point at which bolus transport transitions from a peristalsis to the phrenic ampulla, and it's located within 3 centimeters of the proximal margin of the EGJ. Thirdly, the distal contractile integral, or DCI, it measures peristaltic vigor. So it's calculated by the amplitude, duration, and length of the distal esophageal contraction. And the normal is 450 to 8,000. You say there is an absent swallow or peristalsis if the DCI is less than 100, weak swallow if the DCI is 100 to 450, and it's normal if it's 450 to 8,000, hypercontractile if it is more than 8,000. That would be in a jackhammer esophagus. Distal latency, normal is more than 4.5 seconds, and if it's less than 4.5, we call it premature. And this is the time from the upper esophageal sphincter relaxation to the CDP. And we said the CDP was contractile deceleration point. Peristaltic integrity. This measures gaps in contraction. And if it is more than 5 seconds, we call it a fragmented swallow. And then there is esophageal pressurization. Pressurization is when liquid is trapped between two esophageal contractions. If more than 30 millimeters, it's abnormal. Pan-esophageal pressurization is pressurization that is from the upper esophageal sphincter to the esophagogastric junction. This is eclasia type 2. Compartmentalized pressurization would be seen in distal outflow obstruction. High intrabolus pressure would also be seen in distal obstruction, example in a tumor.